What if I told you that the most common advice you see online for fixing midlife libido is just completely missing the mark?
Oh, you mean like some wellness influencer telling you to just slap on a testosterone patch?
Exactly. It completely ignores the actual physical, mechanical reason why sex just suddenly stops working for so many people.
Yeah, it really does. It entirely skips over the physiological reality of what is actually happening to the body. And the problem is because nobody really talks about the mechanics of those changes, the immediate assumption for so many women is almost always inward facing.
Right. They blame themselves.
Exactly. They think, there's something fundamentally wrong with me. I'm broken, my drive is dead, or gosh, my relationship is failing.
Which is just a devastating place to be. I mean, you're waiting for that familiar spark of arousal, and nothing happens.
Yeah.
Or you're putting in the work, going through the exact same motions that have reliably led to an orgasm for the past, I don't know, 20 or 30 years, and it's just gone.
Right. The system just doesn't respond the way it used to.
But for you listening right now, the ultimate curious learner who really wants to understand their own biology, we are changing that narrative today. This deep dive is focused entirely on how you actually address changes in sexual response, arousal, and orgasm during menopause.
It's such an important topic.
It really is. We are taking a massive stack of sources, including international medical guidelines for the Menopause Society, clinical trials on pelvic floor, physical therapy, and expert consensus papers to build you a concrete, evidence-based toolkit. Okay, let's unpack this.
Let's do it, because I really want to set a very clear baseline right from the start of this deep dive. These changes you might be experiencing in midlife, they are not personal failures.
No, not at all.
They are not psychological flaws or a lack of love for your partner. They are highly predictable, completely mechanical, biological shifts. And more importantly, once you understand the underlying mechanics of what is happening to your cellular tissues and, well, your blood flow, they are entirely treatable.
I really appreciate that word mechanical because it instantly removes the shame, right?
Exactly, it does.
It turns this deeply personal crisis into like an engineering problem.
Yeah.
So let's look at the biological reality, because parsing through these clinical papers, the core issue really just comes down to supply lines.
That's a great way to put it.
Right. As estrogen and testosterone decline during perimenopause and menopause, the blood flow to the pelvic region just drastically drops off.
And what's fascinating here is how heavily dependent that entire pelvic region is on those specific hormones. We are talking about a condition known clinically as genitourinary syndrome of menopause, or GSM.
GSM, yeah.
If you haven't heard of it, you really need to, because up to 80% of menopausal women experience it.
Wait, 80%? That is huge.
It's massive, and it's because the vagina, the vulva, the urethra, and the bladder are just absolutely packed with estrogen receptors. They basically rely on estrogen to maintain their architecture. So when that hormone drops, those tissues go through atrophy. They thin out, they lose their structural elasticity, and the natural lubrication that you used to just take for granted simply stops being produced.
And the symptom of GSM that really stopped me in my tracks in these sources is clitoral atrophy.
Yes, that's a big one.
Because we never talk about the clitoris aging. I mean, society talks about erectile dysfunction in men constantly.
Constantly. There are pills for it everywhere.
Exactly. But we completely ignore the fact that the clitoris is a highly vascular organ. It relies entirely on robust blood flow. The sources point out that due to this hormonal decline, the clitoris can actually shrink.
It does.
It loses nerve sensitivity.
Yes.
It can literally become numb. That right there is the direct physical cause of those delayed or completely missing orgasms.
The anatomy of it is really critical to understand here. The clitoris isn't just the small external structure we typically think of,
Yeah.
It has this complex internal root system of erectile tissue that wraps all the way around the vaginal canal.
Right. It's so much bigger than most people realize.
It functions very much like a penis in that it requires a massive influx of blood to engorge, expand, and push those nerve endings to the surface so they can be stimulated.
Okay, so it physically changes shape.
Yes. When estrogen and testosterone levels drop, that intricate vascular network shrinks. The blood vessels literally narrow, the nerves are physically buried deeper under the tissue, and they just do not fire as easily.
The analogy that crystallized this for me while reading the clinical descriptions is a sponge.
Oh, I love the sponge analogy.
Right. Think about a cellular structure acting like a sponge that's been sitting on the edge of your sink for a week. It's stiff, it's brittle, and if you try to bend it or force it to do something, it might actually tear.
It's completely dried out.
Exactly. That is your clitoral and vaginal tissue without the constant water of estrogen and blood flow. It simply cannot expand, engorge, or respond to physical stimulation the way it used to, making an orgasm physically, technically difficult.
And because the tissue is acting like that brittle sponge, vaginal-only stimulation is rarely enough during and after menopause.
Because it's just friction at that point.
Exactly. The friction without the underlying engorgement isn't just ineffective. It can actually be actively painful.
Ouch.
Because of that, direct clitoral stimulation becomes not just a preference or like a fun addition to your routine, it becomes an anatomical necessity to achieve an orgasm. You have to provide highly concentrated direct input to those diminished retreating nerve endings just to get the same result you used to get easily.
If we are dealing with a dried out, structurally compromised sponge, throwing systemic hormones at the entire body seems like a massive overcorrection, at least initially.
It's like using a fire hose to water a houseplant.
Right. The sources suggest targeting the mechanics locally first. How do we bring the moisture and the blood flow back to that specific area?
We absolutely have to address the tissue quality first, and there's a very important distinction in our clinical sources that gets endlessly confused in the wellness space.
The moisturizer versus lube thing?
Yes, the fundamental difference between lubricants and moisturizers.
It's funny how marketing blurs those lines, but chemically, they serve entirely different functions.
Yeah.
It's basically the difference between applying a daily face cream to heal your skin barrier versus just throwing on some lip gloss for an hour.
That is the perfect way to look at it.
Vaginal moisturizers, which our sources note often contain hyaluronic acid to actively draw water molecules into the cellular matrix, they are designed to be used regularly. We're talking 2 to 3 times a week.
Right, as a maintenance routine.
Their job is to mimic natural secretions, restore the acidic pH of the vagina, and actually improve the tissue over time.
They are maintaining the environment. A lubricant, on the other hand, is reactionary.
Right, lube is the lip gloss. You apply it strictly for short-term friction relief right before you have sex.
Just in the moment.
Whether you choose water-based or silicone-based, depending on your needs, it does not heal the tissue long-term. It just prevents tearing right then and there.
That daily maintenance with a moisturizer is crucial to getting that sponge to soften up. But a soft sponge doesn't automatically mean a functional vascular system.
Right, we still need the blood flow.
We still have to force blood back into that dormant network. And our clinical physical therapy sources point to a highly effective mechanical tool for this. It's called pelvic floor muscle training, or PFMT.
Okay, I have to push back on this for a second.
Sure.
When I read pelvic floor training, my mind immediately goes to doing Kegels to stop yourself from peeing when you sneeze. If the core problem here is a fundamental lack of hormones driving the blood flow, how does simply squeezing muscles in your pelvis actually fix arousal and orgasm?
It sounds totally counterintuitive.
It sounds like telling someone to do push-ups to cure a thyroid issue.
I completely understand the skepticism because it sounds too simple. But let's look at the underlying physiology. Your pelvic floor muscles form a supportive hammock at the base of your pelvis, but they also wrap directly around the base of the vagina and connect to the roots of the clitoris.
Okay, they're physically connected to the structure.
Yes. When you deliberately contract those muscles, whether through focused Kegels or dynamic yoga poses like child's pose, you are physically compressing the surrounding veins and arteries.
Oh, I see.
You are acting as a manual pump. This forced circulation counteracts the lack of estrogen by manually enhancing engorgement. You are essentially bypassing the hormonal trigger and forcing the blood back into that vascular network through sheer mechanical pressure.
Wow, so you're overriding the biological deficit with physical force.
Yeah.
That makes perfect sense.
Yeah.
But the clinical data gives a very specific timeline for this, right? It's not an overnight fix.
Oh, far from it. This requires patience and a lot of consistency. The physical therapy trials show it takes about 1 to 2 weeks of daily targeted exercises just to feel the initial changes in your voluntary muscle control.
It's to feel it.
Right. You are basically waking up the neural pathways that have gone quiet.
So definitely not a quick fix you do in the car on the way to date night.
No, definitely not. It takes a full 7 to 12 weeks of consistent practice to see noticeable, measurable improvements in physical arousal, the return of some natural lubrication, and an increase in the intensity of your orgasms.
7 to 12 weeks, that's a real commitment.
It is, and the trials note it takes 3 to 6 months to build long-term muscular endurance.
The sources also specifically highlight a technique within this training called quick flicks.
Yes. Quick flicks are fascinating. They are rapid, intense contractions. You squeeze the pelvic floor and release it as fast as you can, over and over in rapid succession.
What does that do differently?
Well, what that specifically targets are the fast-twitch muscle fibers in the pelvic floor. Those particular fibers are the exact physiological engine responsible for the pulsing intensity of an orgasm.
Wait, really?
Yes, so by doing quick flicks, you're literally strength training the very muscles that execute your orgasms.
Okay, I am completely sold on the manual pump concept. But it feels like we are treating the symptoms of a larger power outage.
How do you mean?
If the grid goes down, manual generators only get you so far. Why aren't we just turning the power back on with hormones? Because if I look online right now, every influencer is telling women they need a testosterone patch to fix this. Here's where it gets really interesting.
It really is the single biggest misconception in modern menopause care. Social media influencers are currently touting testosterone as the missing third hormone.
Yeah, I see it everywhere.
The pervasive narrative is that it plummets suddenly the minute you hit menopause, and that replacing it is a magical systemic cure-all for everything from low libido and vaginal dryness to brain fog, joint pain, and weight gain.
It's pitched as a miracle drug. But when we look at the actual clinical reality in our stack of sources, the data tells a deeply contrasting story.
To understand the reality, we really have to look closely at the research of Professor Susan Davis. She is a globally recognized leading expert in women's androgen physiology.
Okay.
Her longitudinal data proves that testosterone does not suddenly fall off a cliff at natural menopause. Instead, it declines gradually with age.
So it's an age thing, not a menopause thing.
Exactly. It starts slowly dropping in your 20s and 30s and actually hits its absolute lowest point around ages 58 to 59, which is well after the average onset of menopause.
Meaning the transition into natural menopause itself doesn't cause some catastrophic drop in testosterone.
No, it doesn't. The only clinical exception is surgical menopause. If a woman has her ovaries physically removed, she will experience a sudden drop because the ovaries produce roughly a quarter to a half of circulating testosterone.
Right, that makes sense.
But for a woman going through natural menopause, the gradual decline is simply a byproduct of cellular aging, driven more by the adrenal glands over time than the ovaries suddenly shutting down.
This raises an important question, though. If it doesn't plummet at menopause, and the science is clear on that, why is the wellness industry universally screaming that you need to replace it to fix your menopausal symptoms?
Because missing hormone is an incredibly easy, profitable narrative to sell. But it is not evidence-based medicine. According to the international clinical guidelines from the leading menopause societies, systemic testosterone has only one evidence-based indication for women in midlife. Just one.
And what is that?
Hypoactive sexual desire disorder, or HSDD.
Let's clearly define HSDD because it's highly specific. It is persistent, distressing, low sexual desire. It's not just, I'm exhausted from work and don't feel like it this much.
Right, it's not normal fatigue.
No, it's a profound absence of sexual thoughts, fantasies, and desire that is causing the woman significant personal distress. And crucially, it cannot be attributed to another medical issue, a medication, or a relationship problem.
And even in cases of diagnosed HSDD, the medical guidelines clearly state that a blood test for testosterone levels does not predict a woman's libido.
Wait, really? The blood tests don't correlate?
They don't. You can have clinically high testosterone and zero libido, or clinically low testosterone and a raging libido. The correlation just isn't there in the blood work.
That is wild.
So slapping a testosterone patch on a woman complaining of general brain fog, fatigue, or vaginal dryness is completely unsupported by the current clinical data.
The true MVP in these clinical guidelines for treating genitourinary syndrome of menopause isn't systemic testosterone at all. It's local vaginal estrogen.
Local estrogen is the undisputed gold standard for this specific mechanical failure.
We're talking about very low-dose creams, small tablets, or flexible rings that are inserted directly into the vagina. The genius of this approach, according to the sources, is the localized targeting.
It goes right to the source.
Because the estrogen is applied directly to the tissue that needs it, it has minimal systemic absorption into your broader bloodstream. It doesn't pass through your liver the way an oral pill does.
Which is huge for safety.
Right. This means it's incredibly safe for the vast majority of women, often even those who have a history of certain estrogen receptor-positive cancers, provided they get a sign-off from their oncologist, of course.
And what it does locally is profound. It physically heals the tissue. It reverses the atrophy by thickening the vaginal wall back up.
It's rebuilding the sponge.
Yes, it restores the acidic pH to prevent infections, and it signals those localized blood vessels to dilate and bring the blood flow back. It rehydrates our sponge metaphor from the inside out.
I also want to highlight another localized tool mentioned in the clinical papers that addresses the blood flow specifically. It's topical sildenafil, sometimes referred to as Omazing cream.
Ah, yes.
Sildenafil is the active chemical ingredient in Viagra, but formulated as a customized cream for women, it's applied directly to the clitoris. The sources explain that sildenafil acts as a targeted vasodilator.
Meaning it opens up the blood vessels.
Right. It physically relaxes the smooth muscles lining the blood vessels in the clitoris, allowing blood to rush in and engorge the tissue right before sex. It's an emerging, deeply science-backed way to mechanically force that localized response when the hormonal triggers are lagging.
It is a brilliant example of using pharmacology to solve a mechanical engineering problem. But we really have to address the failure condition here.
The failure condition.
Let's say a listener does all of this. They balance the local hormones with vaginal estrogen. The cellular tissues are healthy, elastic, and moisturized. They are diligently doing their pelvic floor quick flicks, and they even try a vasodilator.
So the hardware is fixed.
The machinery is in perfect working order, but they still have zero interest in actually having sex. The engine simply won't start.
Okay, that requires us to stop looking at the pelvis and zoom out to the brain. Because ultimately, the brain is your primary sex organ. If the brain is hitting the brakes, it doesn't matter how well the pelvic floor is functioning.
If we connect this to the bigger picture, the very first thing we have to talk about is the neurological impact of pain. I cannot emphasize this enough to anyone listening. Pain unequivocally kills libido.
It's a hard stop.
It is. If sex hurts due to the dryness, the friction, and the micro-tearing associated with untreated GSM, your brain is incredibly smart. Neuroplasticity kicks in.
It learns.
It quickly learns to associate intimacy with physical damage, stress, and danger. It creates a protective pain loop.
It's a biological survival mechanism. Your brain is essentially saying, hey, this specific activity causes us structural damage, so I am going to completely shut down the desire to initiate it. You literally cannot fix a suppressed libido without completely eliminating the pain of intercourse first.
And beyond pain, this brings us to a fundamental societal misunderstanding of how desire actually functions in midlife.
This is where researcher Emily Nagoski's concepts, which are heavily cited in our sources, are so incredibly liberating. There is a massive friction between societal expectations and biological reality.
Oh, absolutely.
Hollywood has trained us to expect what science calls spontaneous desire.
Yeah.
That's the feeling of just getting horny out of the blue. You're folding laundry, doing the dishes, and suddenly a spark hits and you're in the mood.
Right, the lightning bolt.
When that spontaneous spark inevitably fades in midlife, women think they are utterly broken.
But the clinical research shows they aren't broken at all. What they are experiencing is a highly natural biological shift toward responsive desire.
Responsive desire flips the script. It means arousal only builds in direct response to pleasurable stimulation and context. You do not start out in the mood, you start out entirely neutral.
Yes.
But if your partner starts kissing your neck, or you start relaxing in a warm environment and experiencing non-pressured physical touch, the desire slowly catches fire in response to that specific action. The sources make it unequivocally clear. Operating purely on responsive desire is completely 100% normal human biology.
It is the daily reality for a huge percentage of women, particularly those navigating midlife and long-term relationships. And understanding this allows us to look at the biopsychosocial web of female sexuality.
Yeah.
Libido is not a singular hormone level you can isolate in a blood test. It's an intricate, fragile web. It is actively suppressed by certain medications. SSRIs used for depression and anxiety, for example, are notorious for dampening the arousal pathway.
Totally.
It's suppressed by elevated cortisol from relationship conflict. It's suppressed by the sheer physical exhaustion and the heavy mental load of caregiving for teenagers or aging parents. It's affected by the grief of body image changes.
Which perfectly illustrates why the testosterone narrative is so fundamentally flawed. You cannot just slap a hormone patch on an exhausted, chronically stressed woman who is experiencing painful sex due to atrophy and expect fireworks.
No, it doesn't work like
It's intellectually dishonest, it's not fair to her, and it's fundamentally not how human biology works.
You have to address the holistic context of her life.
And part of addressing that context, which the clinical consensus papers strongly emphasize, is open, radical communication with your partner to dismantle performance pressure.
This is so important.
Acknowledging out loud that, maybe penetrative sex might not work for a few months while you are utilizing local estrogen to heal those tissues. Taking penetration completely off the table and shifting the focus to outer course, extended clitoral stimulation, or just mutual massage.
Lowering the stakes.
Exactly. Removing the pass-fail pressure of a traditional orgasm is sometimes the exact neurological signal the brain needs to finally release the brakes and allow arousal to happen.
Because when the brain genuinely feels safe, unpressured, and knows it won't experience pain, it can finally shift its resources from protective vigilance back to pleasure.
So, what does this all mean? We've covered a massive amount of physiological and psychological ground today. For you listening, we want to distill this into your ultimate evidence-based toolkit for reclaiming your sexual response.
Let's recap it.
First, treat your localized tissues with the same care as the skin on your face. Moisturize regularly with hyaluronic acid to rebuild the cellular matrix. Second, train your pelvic floor with quick flicks to act as a manual pump, forcing blood flow back to the fast-twitch fibers. Third, talk to your doctor about local vaginal estrogen, the actual gold standard, to reverse atrophy and heal the tissue without systemic risks. Fourth, grant yourself the grace to understand that your desire might be fully responsive now, not spontaneous, and that is biologically normal. And finally, don't fall for the testosterone cure-all myth without a rigorous medical assessment for HSDD.
The ultimate takeaway here is that you do not have to quietly settle for a diminished sex life. The changes you're experiencing are biological, they are mechanical, and they are emphatically not personal.
Not at all.
As the clinical data outlines, you have highly effective, targeted tools to address every single aspect of this transition.
It's incredibly empowering to pull back the curtain and look at the actual mechanics behind it all. It changes the entire internal monologue from I'm broken and aging out of intimacy to I just need to apply a different physical and mental strategy.
It changes everything. And I want to leave you with a final provocative thought to mull over as you process all of this. We've spent a lot of time today discussing the loss of spontaneous desire as a mechanical, hormonal consequence of aging. But what if we zoom out and look at it through an entirely different lens?
Okay, I'm listening.
What if the fading of your spontaneous desire isn't a biological failure at all, but actually an evolutionary invitation?
An evolutionary invitation to do what?
An invitation to radically slow down, to communicate your desires and boundaries more deeply and honestly than you ever had the courage to do in your 20s.
Oh, what?
To redesign your sexual intimacy so that it is no longer just a routine, spontaneous reflex driven by a hormonal surge, but an entirely intentional, customized experience of pleasure. If the biological sponge is dry, it is actively forcing you to stop running on autopilot.
It's a hard reset.
Exactly. It is challenging you to consciously choose exactly how you want to be touched, how you want to be loved, and how you want to be satisfied in this next, more deliberate chapter of your life.